Myers. Thank you,
Okay.
Dr. Myers. Thank you, Dr. King. Thank you, Dr. Naman. Thank you, everyone, for joining today. I'm very excited to hear and learn and bridging the gap between East and West. The best brains from both sides will help us improve one patient at a time. That means a lot, and all of our other wonderful nurses and doctors will learn from the wisdom from East Coast and West Coast of America. And I will let Dr. King take it from here.
Well, good morning. I too share your enthusiasm about this meeting and the opportunity to get to know each other and hopefully eventually visit each other as we move forward. Dr. Meyer and I have reviewed the case, and there are a lot of interesting aspects of it. But one thing that we thought might be nice moving forward, not necessarily today, is that everyone has a short, very short bio so that, maybe even 3 lines so that we can sort of know who we're talking to and where everybody's from. And because I hope over the next year or so we get to know each other better and better. We thought perhaps the best way to open this is to go through the slides, have the presentation of the case, and then if everyone who is listening could feel free to jump in if there's an aspect that they think is interesting. We have a few comments. Every individual case has its own little nugget of interest. In this case, it would be PD in a person with cirrhosis and ascites, and also culture negative peritonitis. There's a lot of sort of interesting aspects of the case presented, but we thought we'd start with a presentation.
Yeah, and if I could just make one housekeeping suggestion. If as we Andy and I thought that as we go along, the two of us would try to keep our mouths shut, but that we thought that everybody else should be prepared, should be able to comment as the case proceeds. I'd suggest doing that by using the hand raising on Zoom so that we're not talking over each other. And then, Dr. Tarif, you could moderate and decide if you want to interrupt the presentation to allow a raised hand to speak, if that's reasonable.
Sure, sure. So thank you very much. I'm really excited. Dr. Andy King is the Chief Medical Officer and for Byonyks in North America, and he's also the home dialysis. He runs the biggest home dialysis unit in the California region, and we're really excited. And Dr. Klemens Meyers is professor of medicine at Tufts University. He has a lot of experience in dialysis patients, including PD and hemodialysis and clinical nephrology. And it will be really exciting to hear the comments. And as we move along in the future sessions, we'll learn more about our cases where we run into difficulties in peritoneal dialysis. Yeah, this case is an interesting case because he was in far off areas from where we are, and we managed him over the phone, and we also were, and he was quite okay over the time, and we were really excited, how wonderful he was doing on home dialysis and peritoneal dialysis, as you can see in this case presentation. I'll hand over to Dr. Atika. She's our medical officer at Byonyks, and she's going to explain the case.
Hello, everyone. I'm Dr. Atika Altaf. I'm a medical officer at Byonyks. It's a privilege for me to be the part of this conversation. So, without further ado, let's just dive into the conversation. I'll be sharing the case. So, as we know that peritonitis is basically a very important complication in the peritoneal dialysis patient, and as it's basically affects the patient outcome and treatment efficacy. So, we had a case of patient 78 years old male. He's diabetic, he's hypertensive, he's having multiple comorbids, including the stage 5 chronic kidney disease, along with the chronic liver disease from hepatitis C, with the resistant ascites. He was having he was on hemodialysis for the past 2 3 years, but in the last 2 3 months, his dialysis session have been very challenging, marked by the frequent hypertensive episode. He was having worsening ascites, which was significantly affecting his quality of life and his daily activities. So, as he was living 600 kilometers away from the Lahore in the remote city of Pakistan with no access of nephrology, this is a situation faced by a significant percentage of dialysis patient in Pakistan. Recognizing this gap, his son approached Byonyks for help, seeking peritoneal dialysis as an alternative to his father resisting ascites and frequent hypotensions during the hemodialysis. So we offered him CAPD, and the catheter was successfully inserted on 24th October 2023, and the patient was transitioned to peritoneal dialysis. His condition was improved, and he has a 360-degree enhancement in the quality of life, characterized by his increased mobility and his activities. So, having retired from the army, he was actively managing his farm. His vital were stable during the peritoneal dialysis. He has having minimal peripheral edema. His medications include beta blockers, diuretics, and oral hypoglycemic agents, which have contributed to the excellent control of both hypertension and diabetes. So, the patient experienced his first episode of peritonitis on November 29th, approximately 1 month after the PD catheter insertion. So, this peritonitis was classified as a culture negative, and on investigation, the most likely cause being a lapse in adherence to the hand hygiene protocol. So we try to manage the patient according to the standard guidelines for culture negative peritonitis, including the 2 week course of intraperitoneal vancomycin therapy. And as you can see, the patient was having, okay, so the patient was receiving monthly calls but had not in-person visits for a year since the catheter insertion. So on 5th October, patient complained cloudy effluent and there was a decrease in ultrafiltration lower than he expected. So we repeated we had sent the cell count and culture for the analysis. At the same time, we had started empiric antibiotics, including the gentamicin 40 gram for 3 days and ceftazidime and vancomycin intraperitoneally till the culture report. And for prophylaxis, we had added oral nilstatin. And the cell counted came back on 8, showing the TLC count of 31 with the increase in lymphocytes. The fluid was getting cleared by the end of 5th day, but it became cloudy again on the 12th October. And at this time, the TLC count was 214 and with the predominant neutrophils this time. And on the culture and gram stain, we were unable to find any organism.
Go back, Dr. Atika.
Yes, sir.
Yes, here.
So we
Uh,
advise, yes, sir.
previous slide, please.
Yes, sir.
As you can see here, when we thought that there was most likely initially a possibility of maybe spontaneous bacterial peritonitis because of a CLD, and he was converted to oral ciprofloxacin because there were very few WBCs and lymphocytes more, and neutrophils were quite small amount. But anyhow, we continued with the vancomycin, and so he improved. Yes, please. Then the previous slide.
So when the fluid became cloudy again. The TLC was 214 with the predominant neutrophils this time. So we initiated the gram-negative cover and advised him to visit Lahore. So the patient was admitted on 17th October on the hospital. His intraperitoneal ceftazidime and vancomycin were continued. So during this period, we were as the patient was having the assisted CAPD, so we were unable to find any clue of contamination. So at this time, his son inquired if performing the CAPD in the open air could have been contributed to this issue this time. As the patient was very active, he was managing his farm, he bought a new piece of land, and there was a delay in performing the exchanges. So at time, the exchanges were performed in open air in the fields. So we presume it could be some contamination from the bacteria or fungus. So we have added fluconazole, 150 milligram, once daily for 10 days in the treatment regime. And after the 5 days of combined therapy, the effluent became cleared. And we tried to, and we have changed the catheter in extension while the patient was still on antibiotics and antifungal. And we have sent the sample after that, but the TLC was persistently increased up to 400, and on culture and gram stain, there was no organism seen. So as the patient was having cefixime, so we had started cefixime on November 4th for 2 weeks and continued his fluconazole, but there was no improvement in TLC and it was 113 on 5th November. So we presumed we thought it could be continuous fungal peritonitis. So we plan to remove his catheter on 22nd November and give him rest for 4 to 6 weeks, and we'll plan the reinsertion after that. Currently, the patient is on hemodialysis. So in this table, you can observe the patient was able to maintain his hemoglobin throughout the peritoneal dialysis, and his urea and creatinine were also in the acceptable range. His electrolytes were also normal. There was a decrease in albumin at the start of peritoneal dialysis, but as soon as we had initiated peritoneal dialysis, his nutrition was improved, so his albumin was also raised. This sheet, you can see we are providing this documents or this sheet to our patients so they can monitor their daily exchanges, and we can have an idea what their ultrafiltration is, and we can see how the patient is managing or on CAPD. So the point for discussion from our side is what to do with the cloudy dialysate and indeterminate WBC count, or which organism to target if its open area exchange are done. Are there any different protocol over there? Any specific diagnostic tests that can help us? What are the individual situation where we can alter the ISPD guidelines for the empiric treatment of a suspected peritonitis? So cloudy dialysate versus chylous fluid, suspicion or management. So that's all from my side. I would like to continue Dr. Numan from here.
Thank you very much, Dr. Atika, for the presentation. And as you can see,
Yes, sir.
we were so excited about this patient improving almost 360 degrees. And we had all actually, done some movie clips, asked them to, send us movie clips while he's walking on his farms and enjoying his time. It was a really turnaround, and we were so happy to see that. But this maybe, some of our patients, they get so much better in their in the treatment duration that they tend to forget few important things. And from here, I'll just let Dr. Clemens and Dr. Andrew King to take over.
Klemens, you want to start? Want to kick it off?
Sure. So there are a lot of interesting points here. Why don't we start with the ones that you've raised? First of all, I had a question. This reflects my my ignorance. When you report the peritoneal fluid, the total cell count you report is TLC. Is that total lymphocyte count?
Total leukocyte count.
Leukocyte count. Okay, that helps. Okay, leukocyte count. Okay, fine. So it's the total white count. So, um, you know, the thing about the diagnosis of peritonitis is that obviously it is the triad of um, symptoms, cell count, uh, and or differential count. That is whether there's greater than 50% neutrophils, uh, and culture results. And um, I think the standard is that one needs at least two out of the three to make the diagnosis. Um, and but I think one also has to take the prior probability into account. That is, if you have somebody in whom everything has been stable, who you know is very meticulous, and you have transient cloudiness of the dialysate, then and nothing else, then it may not be it may not be peritonitis. It may be a little bit of fibrin that subsequently cleared. And so I think taking the background probabilities into account is important. It's also really helpful if one can to follow serial peritoneal leukocyte counts. And and I don't, this man lived in remote from Lahore. It sounds as if though you're able to get peritoneal cell counts and cultures done locally.
No, actually, we had to send it out to a local lab that transferred it to Lahore, where they
So,
were finding. So we got the results like 2, 3 days late.
and so, I think that this gets us immediately into one of the core problems that we all face, which is the laboratory details. I mean, we've been exposed to this recently because our health system is poor by American standards, and they outsource their laboratory work. And so we're in Boston, and our routine labs are now sent to New Jersey and get lost on the way. Um, but so seriously though, so if that the it would make me wonder what the techniques are, about how the fluid is being handled, and whether um, you know how how reliable the cell counts are as compared to somebody. If it's the same, if it's your hospital laboratory and you had a patient in the hospital, and the fluid went directly from the inpatient floor to the lab, or you have this man remote and the fluid comes over a matter of several days, is the performance of the laboratory in that setting comparable? And I think that that's something that would be, maybe potentially worth investigating. Um, I
Clemens, can
think,
I jump
yeah,
in here?
sorry. Yeah, please.
Yeah, one other aspect this raises is the culture technique,
Yes.
because we know that culture negative peritonitis, depending on where you look, the percentages can be as high as 40 to 60%. And that technique probably makes a very big difference. And in our own institution, we noticed that our culture negative, it was rising to 30, 35%. And I sort of said, we need to investigate this. And it turned out that the emergency rooms were not using blood culture bottles for the dialysate cultures. And we changed that practice, and our culture negative rate dropped to below 20%. And so these things matter. And another thing, getting to Clemens's point about being far away, is that there's data that if you refrigerate the culture, you're less likely to get a positive. And so the handling of the specimen over distances probably makes a difference as well. Some have actually been take 500 cc's, spin it down, and take the sediment and culture it, and that too can increase your sort of sensitivity of your cultures. We have not done that. We typically do 5 mLs into an anaerobic and aerobic blood culture bottles, and we find that within the home dialysis therapies of San Diego, we find that we average roughly 18% culture negative.
So just to add on a little bit to that, I agree. I've wanted to do the centrifuging. It can apparently increase the yield by tenfold. So it and the problem for Andy and me is that we work in these big institutions, and getting somebody to do something as simple as install a centrifuge and use it is a major effort. Paradoxically, you might have centrifuges are not that complicated. You might have more luck in a resource stretched environment to put a centrifuge somewhere remotely. And people have talked about centrifuging even, I think the standard is 50 mLs, but as Andy said, you can take even more. So I think that's a very promising technique. The other thing is that fungi and molds are harder to grow. I looked this up last night and this morning, and so they're more likely to be culture negative. And in addition to the blood culture bottles, and this goes beyond the microbiology at my fingertips, I think there are some additional techniques that can be used. And I think that one of the points that this would bring up would be, maybe you already have identified a microbiologist, who will take an interest in this and help you to figure out the best approach. Should we go on to the open area?
Well, before we do,
Yeah.
in conjunction with that, I think our whole approach to peritonitis is evolving. And that, as we have seen with blood cultures and the use of Verigene to help identify early the type of bacterial overgrowth or growth or fungal growth, I think that's going to enter our PD realm very quickly. And there are techniques related to DNA footprints, RNA footprints, next-gen sequencing, and it's not yet clear exactly which one is going to be the winner, but there are going to be the winners, and it's getting better and better, so that probably in the not too distant future, we will have the ability to identify even fastidious organisms, which probably are, as Klemens alluded to, probably are, these culture negatives are probably fastidious or organisms. So we'll have, I think, genetic ways to get to that diagnosis in a much quicker fashion.
Yeah, I noticed in the final culture result that you were using some sort of genetic probe to rule out tuberculosis, and I actually did some looking, and looking about fungal peritonitis in particular, and I have a slide. There was a study from China, from North China, I think from one. I may be confusing studies now. Anyway, that was that was 11 cases of Candida peritonitis. Anyway, there's a galactomannan assay, but the problem is that the test characteristics aren't very good. The sensitivity was only 62% or so, and the specificity wasn't very good. But that could be something for early diagnosis. The other thing that I found, just going back to the diagnosis of the the cell count is that there are, I hadn't known about these are not new, but there is at least one test strip that is made for peritoneal fluid for leukocyte count. Have you ever encountered that?
No, we don't
Okay,
have
so
it.
yeah, it's interesting. I didn't go so far. I couldn't get the price. I went on. I found the website. It's a company in New Jersey. I have a slide. I'm not advertising them. I didn't go so far as to order because I didn't have time, and I didn't I to see what the price was. You can't see the price immediately, but that would. And there was a study. The way I got to it was that there was a study showing that those had very good those strips had very good test characteristics. So that might be something interesting to use, just to, as a, and I can give you the reference. I think it was in the ISPD guideline that I found it.
The other thing, getting back to the next gen, I found a very nice article of 30 patients basically demonstrating that the sensitivity of this technique could be as high as 97% with a specificity of 83%, versus, for most culture techniques, it's roughly 71% sensitivity or in that range. But of course, specificity is 100%, if you get a positive culture. One of the things that Byonyks is involved with, which I think is really part of an exciting element of X3, is that it will incorporate a way to determine whether or not leukocyte count is rising. And so that hopefully we can push back the diagnosis. There is a company, the name of which is eluding me, Cloudcath, that has a flocculimeter basically that looks at the sort of cloudiness of dialysate and they have some early data that suggests that it can make a difference of making the diagnosis much sooner, because we think, the question is, what's the natural history of peritonitis? Is it really quick like that, or is it, maybe slower than we think? And maybe we see earlier that there actually are leukocytes earlier on. So I think this is going to be an exciting sort of area of research that the X3 will and X2 actually will allow us to do. The other thing that changes and occurred in this patient was changes in membrane characteristics in terms of, ultrafiltration rate. And, if the promise of X2 really and X3 really come through, we will be able to get a membrane integrity index too. And that also might be another early indicator of an infection. Because we know that the permeability of the membrane changes relatively, substantially in an infectious. So I'm looking forward to sort of pushing back the diagnosis of peritonitis utilizing these tools.
You mean making it earlier?
Yes.
Yeah, I mean, and I think one thing that I was reminded of in preparing for today is the importance of prompt antibiotic treatment once you have the sample. And of course, this, on the one hand, we have that we're all trained not to overuse antibiotics. And it may be that the key here is to be willing to be relatively promiscuous with antibiotics once we've gotten the fluid, but also be prepared to stop and not if we don't think that the diagnosis is correct, so that we don't expose people to we don't encourage too much resistance.
And this does raise this open air question. We take some information from OR data, and there's pretty clear data that even people moving around the OR heightens the risk of a wound infection. And also opening the door and closing the door, people coming in and out of an OR, in joint replacement has an impact on infection rate. So the fact that some of the exchanges were being done under a tree certainly could have had an impact on this. And both Klemens and I were unaware. We educate patients to close the door, close the windows, etc. But I'm not aware of any sort of data that's really looked at that. It's just I think this fits into the common sense category. But
I had a similar patient who was on peritoneal dialysis for 5 years in a village, and he was having assistance from his wife. And one day she had to go to the other village for some condolence, something. He said, "I'll do it," and he did it in the open area, and he got his infection. And unfortunately, he was far away, could not get the antibiotics, and he never had an infection for 5 years. That was amazing. But I mean, we have these experiences here.
Yeah, I remember when I was a fellow, we had a patient doing CAPD who would go somewhere on holidays to somewhere on islands, and he would do his exchanges on the beach, and he seemed to get away with it. But I think, there clearly are, clearly it's a risk. I'm sort of nihilistic. I'm skeptical about dogma. So I went, I was wondering, was all this true? And then I found the OR literature, which is very strong. And actually, I was hoping to find something about infection rates in field hospitals, military hospitals, but I couldn't find anything. Um, I did find that the first work on this was actually done by Florence Nightingale on the Crimean War, where they observed such high infection rates. And she apparently helped to design the next hospital, which I guess because of ventilation restrictions had much lower infection rates.
Interesting. Well, I think the other thing that you alluded to is technique drift. And peritoneal dialysis is a marathon. It is not a sprint. And it is hard for all of us to do things every day the same way. And so technique drift and a little lapse or something like that. And we of course know that the story about the wife leaving. We know that probably women are much more fastidious and less likely to screw it up than men. But probably we have thought about this because a year or two ago we saw a little increase in our peritonitis, and we thought multiple hits on instruction. When persons start peritoneal dialysis, they're uremic, they're nervous, their whole family life is up in turmoil. And they learn things, but not quite as well. And so we thought that we would go with a second hit at 3 or 4 weeks with the uremias coming under control. They started calming down. But I think and that did make a difference. We moved the needle. But I think even more sort of hits, maybe at 3 months, 6 months, 1 year, some sort of regular, rebooting of the patients in terms of technique might be advantageous.
Well, and one related thought, I don't know how many of your patients are remote like this, but it would be interesting to and I also don't know whether if they're remote, how many of them have access to broadband video so that you could do it by video. But if you could, or some sort of video, that to do that and to look at the results and to see whether you can develop a nursing protocol for re-educating remotely, that could be very valuable.
Well, I think the other thing is people don't understand that when you get peritonitis, there's roughly a 20-25% chance that you're done with peritoneal dialysis forever. Now, some of that is not necessarily related to the infection, but for a person like this who is struggling on hemodialysis for many years, that's a huge thing. And so that's a motivator is what I'm saying.
So if I interrupt here right for a second, so it's amazing discussion in first 35 minutes. We have really good about 50 audience in there. So in the interest of community building, we have some of the Bionics engineers, nurses, technicians, and some doctors who are from all over Pakistan. I would say if people who are outside Bionics, they joined, I'm really thankful for them. And if we can take some doctors' questions, then we can take some nursing question. Really quick, short questions. If Dr. King and Dr. Myers and Dr. Numan allow me to do that. Is that a good idea?
Can we have the slides from Dr. Myers? Do you want to share them and
Yep.
maybe?
Okay. Okay. I mean, these are really quite well. What about having thoughts? Do people have thoughts at this point? And then I don't want to. So before I go, and then we can look at.
You can take
Sure.
1 or 2 thoughts or 1 or 2 questions, then we can go to Dr.
Okay. All right.
Any questions or any suggestion, please do your small one-line introduction, and then if you have a question, please speak up.
I see Dr. Jveria there in the audience, and she's currently in Canada with Dr. Bagman. She's from Karachi.
Hello, Dr. Numan. How are you?
Hello, how are you?
I'm good. It was a wonderful talk. I enjoyed the whole talk and discussion, especially the yield of cultures by changing the method, especially and adding we have seen the decline of culture negative peritonitis incidents in our center after talking to microbiology and making some changes in the culture process and the collection method.
Great.
In fact,
How low have you gotten it? Do you know?
sorry?
How low have you gotten the culture negative rate?
So we do not have any specific data. We didn't collect it like a data, but when we spoke to, we were having a lot of culture negative peritonitis. Then we had a meeting with the microbiology lab, and we made some changes. Like we started collecting in the blood culture bottles rather than the previously we were collecting in the syringe and sending to the lab. That helped us, and the incubation and the lab door to from the collection point, we worked on that. It shouldn't be left in the counter for the long hours of the time, and immediately incubated, and centrifuge method too.
I think you raise an interesting point because so many people come into the emergency room and they have peritonitis and their belly's empty and they draw culture and you really do need to infuse that fluid, let it rest for a period of time before you draw that culture.
Right. I mean, the ISPD standard is 2 hours, I think.
Right.
Yes, 2 hours.
Right.
Yeah.
And some even do 4, but delay of antibiotics 4 hours feels uncomfortable.
That's true.
Yeah, and I guess the other point that this is something I had wanted to mention is that we've not been good about this, and with the organization I work with nationally we're only getting started on this now, is that we have to collect our data. None of us does enough individually, and so I don't know. Maybe you already have a database, but it would really be, even if you don't use a single electronic health record for care, which you probably don't, to have a national database of peritonitis could be incredible, or of peritoneal dialysis, but specifically of peritonitis could be incredibly valuable, and would both for quality improvement and to advance knowledge. So I would, I'd offer any support I can give with such an effort.
That will be great. At the Pakistan Society of Nephrology, we have a task force for PD where Dr. Faiza and Dr. Javeria and Dr. Shaukat Mehman, they are leading the formation of peritoneal dialysis registry. Along with we have other people, Dr. Ahad Kiyum, and they're all working together. And but certainly, I think we'll go over some of the data points with you, and maybe that will help us in moving things forward quickly.
But would you like me to show what the slides that I found?
Yes, sir.
Please.
Okay, this is, and I should emphasize, this is really, I just have to find where the appropriate,
Clemens, while you do that,
okay,
an additional comment that I would make regarding data is, I think when knowing the sort of spectrum of microbes that grow within your area is really important within your hospital, within your region. And in this case, this was a person with cirrhosis. And interestingly, and probably not surprising to all of you, is that the sort of spectrum of peritonitis differs in those with cirrhosis. And it is much more likely to be gram-negative rods, enteric organisms in that one specific setting, because we know that the translocation of bacteria is more likely in the cirrhotic patient, and so knowing, collecting your own data of what you're actually growing can help, guide the initial choice. And that was one of the questions that was raised, is when do you deviate from the ISPD? The ISPD guidelines I've found have been really superb. But if your local spectrum of microbes differs, well, then that's a reason to actually.
Right. I mean, and so examples would be, what is the local methicillin resistance rate? Is vancomycin necessary as the empiric treatment, or can you get by with a first generation cephalosporin? And it's interesting for somebody like this situation with the open air exposure. I think you might even be able to justify including an antifungal agent as part of right from the beginning. I think taking into account specific risk factors. Obviously, if somebody had a pet cat and you knew, and you would want to be covering for Pasteurella immediately. So these slides that I have are really quite random. They're what I found last night. But I thought they were interesting. So this is something from Kidney International Reports, a new colorimetric and light scatter methods to identify and manage PD-associated peritonitis at point of care. And they had effluent samples of 53 PD patients without peritonitis and 36 patients with suspected and later confirmed peritonitis. This was in the UK. It's a tetrazolium-based chemical reporting system focused on detecting bacterial contamination and vancomycin sensitivity. And I guess the device is called a device called Quick Check, which provides an instant quantitative cell count. So they compared so they're comparing the tetrazolium approach detected and correctly identified distinguished lab isolates, 10 hours for non-quantitative results. The quick check for cell count was 94% accurate, was very precise with minimal bias, and performance overall to flow cytometry. And so there are two techniques here, and they concluded that these would be useful at the point of care. So that's something that might be worth looking into. Again, I have no idea about its availability or its cost, but it is something that's potentially can be done locally. This is from Australia, this is looking at seasonality, because I was, thinking about the way, in particular with outdoor exchanges. So these are unadjusted seasonal organism-specific peritonitis rates in all Australian patients receiving PD from 2003 and 2008. And so here's this is supposed to be a negative, not a one, sorry. Coag negative staph, Corynebacteria, gram negatives, and fungi. And this is the incidence rate ratio. They used winter as the control in all cases. And you can see that there's maybe a trend to more coag negative staph in the warmer weather. I think the argument has been made about staph is that we have so much on our skin that it's unlikely that environmental circumstances are going to cause variation. Corynebacteria are more in the winter, and I think that has to do with the organism and its temperature sensitivity, but I'm not certain. Gram negatives maybe more in the autumn, and fungi more in Australia in the summer and autumn. So there may be some, there is some environmental influence. I also saw a reference to Korea, where certain organisms are more common when it's very hot and sticky. This is fascinating. This was looking at the air in cities and in one smaller place, a town and cities in the Midwest in the United States, and they're looking at the genetic fingerprint in the air of the organisms that are around, and so maroon is summer, and blue is winter, and you can see that in the organisms that are associated with soil and leaf surfaces are more common in the summer, and there's this big cluster of fecal, and it's particularly dog feces, and this is Cleveland and Detroit, and there are a lot of stray dogs apparently running around Cleveland and Detroit, and the bacteria from the feces gets into the air, and this is, I couldn't find anything outside the United States for this sort of thing, but I thought that this was really, really interesting. So this is what's in the air. That doesn't necessarily say that this is what gets into your peritoneum if you do an outdoor exchange, but I thought that the variability was fascinating. So this is looking at the culture negative question, and this is I think from the Children's Hospital of Akron in Ohio, and so they looked at patients who are, so it's pediatrics, but it's presumably generalizable, and they went from so they looked at patients were pediatric patients on PD, and their outcome was a diagnosis of culture positive peritonitis for the outcome and process time, and they went from only 16.7% positive, so a very high culture negative rate, to making a diagnosis in everybody. Now these slides over here, they are compressed. So this is process time. This is pre-intervention. This is during the intervention period. This is sustained phase. This is the average process time, and these are control limits around the data. And you can see that although there were only a few outliers here, they did successfully compress the time, make the time more consistent. And this is what is B? That was the process time. I think there's I'm embarrassed that I can't
I think it's a bedside inoculation of the culture bottles.
it's
So
what?
that the bedside inoculation into the culture bottles.
Right, but the uh, anyway, they compressed both, and by focusing on the process, they managed really to increase their culture yield. I think it was also, yes, it was. I think, but the other thing I think they did is that they made sure that they were using blood culture bottles and not sending a little fluid to the lab that ended up on plates. Um, this is sorry, oops, I have to go. Is, I'm hiding the. This is okay. This is looking at local. This is in Thailand, local unit sampling and their culture practices and their ability to make a diagnosis. So they looked at the peritonitis data and first cloudy bags from 22 PD centers, which they randomly selected from 140 centers in 2016 to 2017, and they submitted the bags to a local and to central labs to compare pathogen identification, and they looked at the association between culture negative peritonitis, local lab practices, and competencies and quality assurance. And they found that culture negative peritonitis was significantly more frequent in local labs, and it was 38%, whereas in the central lab it was only 12%. And they found that lower rates of culture negative peritonitis were associated with the nurse doing it. As always, the nurse does it better than the doctor or the patient. Centrifuging the fluid, immediate transfer to the lab, larger hospital size, larger PD unit size, having a nephrologist on site, higher lab capacity, lab ability to perform aerobic cultures, so basically, I think a lot of these latter factors are just, how the measures of the quality and the technical capability. But the really important things are obviously the adherence to technique as measured by whether the nurse did it, the centrifugation and the time. Those are modifiable things. This is from the UK, just so that none of us feels bad. The UK, they did a survey of culture negative peritonitis and dialysate sampling practice. This was in 2016, and this is the self-reported in 53 centers that reported the culture negative peritonitis rate. The median is 15. You can see that the range is 5 to 38%. And this is this is sediment and blood culture volumes. So how much they centrifuged, and they found a third of the centers they sent the entire bag of effluent to the lab. And this is the blood culture media where a lot of them are doing 20 mLs. I have to say, in our practice, our hospital is in Chinatown in Boston, and we would get a lot of people who would be very upset with us for taking that much blood from them. And these are the test strips I talked about. It's the Serim company, SERIM, Serim.com, that has these test strips. But these may not be as good as the ones that were referred to in that first study that I showed. And this is the galactomannan data about fungal peritonitis, which is not so impressive. You can see here here's the galactomannan index in fungal peritonitis as opposed to bacterial and non-peritonitis. And really, this is the ROC curve, the sensitivity so basically the sensitivity is a function of the false positive rate. And this is not a great test. So that's what I had. Let me end my screen show, my slide sharing. That's what I found. It was just it's relatively fresh data, but sort of random.
Uh, Maybe we should open it up again and
Yeah.
see if more
Yeah,
questions.
there is a question from Dr. Hannah Akbar. She's a consultant nephrologist, and she's asking whether there is a role of starting carbapenems right away if you're getting more of a culture negative peritonitis in the area, rather than just going for straight for ceftazidime and vancomycin for gram negative.
I don't think I can speak from data regarding this question, but just as a general principle, utilizing a bazooka, you if you use a bazooka to treat, your bazooka will become a small gun. And so I think we really do have to be stewards of antibiotics. And so generally speaking, I would reserve that for sort of culture driven results.
Yeah, so I mean, a couple of issues. One, I don't know about giving carbapenems intraperitoneally. I would have to look up whether that's been reported and whether it's. And I think the question is, if are there any data about it? I just don't know. I think that what I would address would be what I would do is I would if I had most of my culture negative, I would take them as a model those people from the Children's Hospital in Akron and do a quality improvement study like theirs and see if what needs to be modified to try to make diagnoses. Andy, I would say a gentle criticism when you said bazooka. One of my most traumatic experiences as an intern was when the attending, who was Dr. Schwartz, Bob Schwartz, who discovered the 6-mercaptopurine could prevent rejection of mouse skin grafts, came in and told me that I had used flamethrower antibiotics. That's an injury that has never quite healed.
Well, you're absolutely right about the data. Local data is very important, and we faced the same thing in our own hospital. We had to sit with our microbiology lab, and we used to send, and still, in that hospital, we send the whole bag to the lab, and they know what to do with it. So they take a, shake the bag, take a large sample, and do all these things, and then we get the cultures very quickly, and they know when to put in the to keep the sample for fungal growth for extended period of time, at least 2 to 3 weeks. So the local data does help, and we need to look into this habit of discussing with the microbiologist.
Well, and you just made me think of one thing. Andy talked earlier about the importance of re-education of patients. But I think that for all of us, we need to remember that, your friend in microbiology is not necessarily immortal and may change jobs, and that it's very easy to fall into complacency and to think, we have this down. We know how to do this. I'm gonna send it to the lab and they know what they're doing. And it's probably a good practice for us to check in with them, at least annually, if not more frequently, and make sure that the things that we put in place are still there.
Clemens, that's exactly what happened with our peritoneal, our culture negative peritonitis, and the ERs changed their pattern,
Yeah.
and there it was. I know we're coming to the end of the hour, but one last point that I would like to raise is, it's about doing dialysis in persons with cirrhosis and ascites. One of the issues raised by hepatologists in particular is the worry that you are going to make these patients more malnourished and/or that their risk of infection is heightened by the fact that the acidic fluid is rich in nutrients. And there are several meta-analyses, et cetera, that suggest that the survival of PD in this setting is as good or maybe even better than it is with hemodialysis. We know that in these acidic patients who are getting paracenteses on a weekly basis, that it's a huge quality of life improvement. We know that hemodialysis is a challenging with advanced liver disease. But I noted that in one sort of large meta-analysis that there was, the odds ratio of an infection was like 1.1. And so you have to balance that. The other issue that arises is whether or not the negative nitrogen effect of peritoneal dialysis on nutrition and albumin levels. Well, there actually are like 3 or 4 studies that have addressed this, and most of the studies demonstrate actually that the albumin levels on peritoneal dialysis are roughly the same as they are. They go down initially and then they stabilize. Perhaps, in part because you have fluid in the belly leading to changes in pressure within the liver. There's speculation as to why. But some of these concerns that people have are probably not 100% founded. And just like everything we do, every case needs to be individualized of who you're dealing with, who's the patient right in front of you. Sorry,
Well,
that sounds preachy.
no, I mean, you touched a very important point because Pakistan has one of the largest number of hepatitis C patients, and I think probably in the top of the world right now. And so we face a lot of patients who have hepatitis C with chronic liver disease on hemodialysis, getting all this problem. And we have converted many patients to peritoneal dialysis, and they have lived quite a good life after that. And you rightly mentioned that peritoneal dialysis is not a marathon, but it's a marathon, not a sprint. So you have to go slow and keep on, training your patients and, re-educate them every now and then. And we do that, but, we still need to maybe because being in a part where the education level or, the access to the health education is less. So we need to probably retrain them again and again, maybe every 4 weeks, every 3 weeks, or weekly sometime initially, and then realign them to the process of peritoneal dialysis. I think it had been a very wonderful session, and I think we are end of the session. However, if there are any certain points, Dr. Andy, Dr. Myers, do you want to any other few words further?
I just want to say thank you. I think this is great. I look forward to future sections and also would encourage everybody to be, to jump in.
Yeah.
You bring your perspective and knowledge base, and we all are enriched.
So
Yeah,
just
and yeah, sorry.
no, go ahead, sir.
Well, I just wanted to say that Dr. Bashir just put a comment about tuberculosis as a problem, um, and maybe we should, maybe should that be a topic for a future,
Right.
and also control and antibiotic use. I mean, I think there are lots of opportunities for future topics.
Absolutely. That would be amazing if you can have more of your time, 1 hour here and there. We would love to learn from you. And one thing I would like to say, Dr. Sulman Imtiaz is here. And for Dr. Myers and Dr. Andy King, there's a huge, massive hospital in Karachi, and it has branches all over. And it's the top quality treatment. And if you go in, you get a transplant or you want to get a major surgery, you can't even pay if you want to. It's free. It's all by donations, all funded by donations. And if you want to pay for your treatment, you can give a donation. So Dr. Sulman is a chief nephrologist
Wow.
there, and that he is our quarterback in Karachi. So he is starting more and more PD patients. Dr. Sulman, thank you for joining, and Dr. Sulman, thank you for leading in Karachi.
And we have other nephrologists, Dr. Azhar Naseem from Lahore, Dr. Batul from Rawalpindi, and Dr. Roshina She's again ISPD fellow in peritoneal dialysis also, and Dr. Shaukat Mehman along with Dr. Salman Imtiaz in Karachi. And there's some many more. There are so many there. So, and I would like to thank every one of them for joining in. And it had been a very useful discussion, and it raised quite a lot of points. And that we are going to look into it and maybe look forward for another session soon.
Sounds good.
Great.
Well, good night to all of you.
Good night. Yeah.
Thank you so much.
All right.
Thank you.
Bye-bye.